All right, so for my capstone presentation for my program, I've decided to do a review session for this course for you guys. I think there's a lot of information over the course of the day or so, and so this is just a way to kind of try to pull everything together and try to clarify certain points and misconceptions for you guys, okay? So, again, this is for my capstone for Drexel University. So, just some objectives. So, at the end, you should be able to identify some common cardiac rhythms and state their potential interventions. So, what you would do if you saw a certain rhythm. All right, and then talking about clinical implications of cardiac arrhythmias. So, you know, if somebody has a high heart rate or a low heart rate, what are some things you might see? What are some changes in the body that you might see? And then differentiating between rhythms, okay, and summarizing concepts of safe handoff. So we'll talk about some cardiac anatomy and physiology review. Okay, I know some of you missed the morning, so this might be extra helpful. So remember, the heart has 4 chambers. You have the top of the heart starting with the right side. You have the right atrium, and that flows down into the right ventricle. Blood is pumped over into the lungs, and then it returns to the heart in the left atrium, down to the left ventricle, and then out to the body. Okay, so your heart is pumping about 4 to 8 liters of blood out to your body per minute. Okay, and it's delivering blood and oxygen to your cells. Okay, out to the vital organs. It's important to know that the heart receives its own blood supply through the coronary arteries. So your heart pumping alone is not getting blood to the coronary arteries if they're blocked. Okay, so if you're running into people with heart attacks or things like that. So with the cardiac cycle, just to review a little bit, so we have Frank Starling's law, and it's kind of like the rubber band law. So we can think about it as, if you have a lot of stretch, you're going to get a lot more pump. Okay, so if you think of like a small water balloon, if you only fill it up a little bit and let go, not much is going to squirt out. But if you fill up a water balloon really full and let go, a lot of water is going to squirt out. Okay, so the more stretch we get in the heart, the more blood can be pumped out to efficiently, pump blood to the body and oxygenate the body. Okay, so we have our 2 cycles. We have our systole when the heart's pumping, and then we have diastole when the heart's at rest. Okay, so when the heart's pumping, the ventricles at the bottom of the heart are pumping blood out to the body. And then during diastole at rest, you have that relaxation of the heart, and that's allowing the heart to fill and allowing the coronary arteries to fill. That way the heart's getting oxygen supply too. So when we think of cardiac conduction, remember, conduction is different from the previous slide where we talked about the mechanical activity. So the actual pumping of the heart. With cardiac conduction, you have like the SA node, things like that. So the SA node up in the top of the heart, remember that's the main pacemaker of the heart. So that's pumping at a rate of 60 to 100 beats per minute. But then when that doesn't work, you have backups. So you can have the AV node at like 40 to 60 beats per minute, or the Purkinje fibers if the AV node fails too. And the Purkinje fibers will go at a rate of 20 to 40 per minute. And that's kind of our last hope. So you can think of the SA node as a brand new car. You turn the key in the ignition and it fires up right away. Okay. Whereas the AV node, you turn the key in the ignition and it kind of struggles a little bit to start up, but eventually starts up. And then when we get down to the Purkinje fibers, you have to really turn the key and hold it there, and the car really struggles to start up. Okay, so that's kind of another way to think about it. And then remember, in the heart we have those cardiac myocytes, the cardiac cells. And so those have that automaticity, like Michelle talked about earlier. And so the automaticity allows the heart to generate its own impulse. So if these pacemakers aren't working perfectly, the heart tissue itself, the cells within the heart, can generate their own beat. Okay? So conduction, what we're seeing here, this electrical activity, is what shows up on the rhythm strip or on the monitor. So the EKG is only showing the electrical activity. It's not showing the mechanical activity. So we can see a nice rhythm on the monitor, but that doesn't mean that the heart's actually pumping. because it's only showing us the electrical activity. Does that make sense?
Mm-hmm.
Okay. So again, electrical activity is that electrical stimulation leading to mechanical activity. So we're only seeing the electrical activity on the EKG, and then the mechanical activity is the actual contraction of the heart muscle itself being able to pump blood out to the body. Okay, and in order to see if we have mechanical activity, we can feel for a pulse. And so if we have a pulse, then we know we have mechanical activity. So I do have some questions built in to the presentation here, just to kind of test your knowledge and see where you're at with things, okay? So take a minute to answer that question.
Put our names.
All right, did everyone have a chance to answer?
Mm-hmm.
So the upper part of the heart is our atria. So you have the right and left atria up at the top, and then the ventricles are down at the bottom. Okay, and the ventricles allow us to pump blood out to the body. Okay? The ventricles are the lower chamber. And then so when we think about electrical activity, we can think about how the QRS is going to look on the monitor based on where it comes from. So take a minute to answer this. So again, what this is asking is if the electrical impulse starts in the SA node or somewhere in the top part of the heart, the atria, how is the QRS complex going to look? So the QRS complex will be narrow if it starts in the top. Okay, and then if the QRS complex is generated from the ventricles at the bottom of the heart, you're going to have a wide QRS complex, like if you have a ventricular rhythm. So now we'll look at some rhythms. I'll put the rhythm up, and then try, the next slide following that will ask you to identify the rhythm, okay? So take a look at this rhythm for a minute, and think about how you would identify that. What would you call that rhythm? And I do have the heart rate listed up in the upper right corner of each rhythm strip. Right. Does everyone have their answer? Okay. So you can type in what you think that rhythm would have been. How would you identify that rhythm? So it seems like the general consensus is that it's normal sinus rhythm. All right. What helps you identify this as normal sinus rhythm?
QRS and there's T wave.
So there's a P wave for every QRS, right?
Mm-hmm.
Is our QRS wide or narrow?
Narrow.
Narrow, okay. And then is this rhythm regular or irregular?
Regular.
Regular, right? So that's how we know it's normal sinus. What else can we look at? The heart rate. So it's between 60 and 100. Okay, good. All right, so what about this rhythm? Everyone ready? So how do you feel about that rhythm? So go ahead and type in your answer. It's okay if you're wrong. It's completely anonymous.
That's what you say now.
No, it is.
The 20s.
So don't be afraid to put your response up there even if it's wrong. Okay, that way we can all learn from each other and we can talk about it afterward. Okay?
That's why you need your type your name in, because he's really new.
All right. Anyone else want to put their answer in?
Only 12 people dancing.
I know there's 17 of you.
There's 18. He was missing somebody.
All right, I'm going to go ahead and put the responses up.
It's going to be like.
All right, so we have supraventricular tachycardia. All right, so it is SVT. How can we decide that this is SVT? What are some things we can look at?
No P waves, heart rate above 150.
The heart rate's above 150. There's no P waves. What about the QRS? It's narrow. Is it regular or irregular? It's regular?
Yes.
Okay. So, yeah, that's how we know it's SVT. So we can't really tell if there's a P wave in here. There's no P wave. It's that it's so fast we can't even tell if there's a P wave. So we can use the heart rate as a clue and the fact that it's regular with narrow QRSs. Okay? So we don't know exactly where it's coming from, but we know that it's coming from somewhere up high in the heart because the QRS is narrow. So because the QRS is narrow and the rate's high, we can call it supraventricular tachycardia. We know it's coming from somewhere up there. Okay? Does anyone have any questions about SVT? All right, so what do we have going on here? Think about that one for a minute. So think about your questions. Do you have a P wave or not? Is it regular or irregular? Is it fast or slow? Think about it like that. Okay? And the heart rate's 170. All right, so you can go ahead and put your responses in. anyone else? All right, so see a lot of VTAC, some VFib, constant, so it's regular. Code, yeah, you'd want to call a code. All right, so this would be VTAC. Okay, so what are some ways we can tell it's VTAC?
Wide QRS.
So we have a wide QRS. Okay, what's our heart rate?
170.
170. Okay, does the patient have a pulse with this? Maybe. We don't know. We have to check first, right? So what if they have a pulse? Condition C, right? And if they don't have a pulse?
Condition A.
And CPR, right? Because if they're in this, are they going to be able to sustain that and stay in that for long and be okay?
No.
No, definitely not. All right, so SVT and ventricular tachycardia have both of the following in common. So what do SVT and VTAC have in common? Do they both come from the ventricles? Are they both regular? Do they both have a narrow QRS? Or are they both always lethal? Deadly.
I don't like anything that says always.
Yeah, always isn't usually a good pick. All right, anyone else? All right, so they're both not always lethal. SVT, you're usually going to have a pulse with. In VTAC, you either will or will not have a pulse. You'd have to check first, you don't know. All right, in SVT, you could have PEA too. So remember, that always goes back to checking your patient. So they don't both have a narrow QRS complex, right? Because SVT is coming from above the ventricles. So we're going to have a narrow QRS, whereas VTAC will be wide. Okay? So they're not both coming from the ventricles because we have supraventricular, which is coming from above, supra meaning above. Okay? And so the correct answer would be that both are regular rhythms. All right? So regular meaning that they have a nice, regular, organized QRS complex. Okay? They're happening at consistent intervals. So again, SVT and VTAC, they both have rapid rates. All right. But the difference is where the QRS is. So SVT, you're going to have a narrow QRS, whereas VTAC will be a wide QRS, okay? And VTAC could or could not have a pulse depending on the patient and their situation, okay? Does anyone have any questions about the difference between SVT and VTAC? I know that can be kind of confusing. All right, so take a minute to look at this rhythm. Think about, again, does it have a P wave? Is there one for every QRS? Is it regular or irregular? And the heart rate's 148. Is your QRS narrow or wide? Everyone ready? All right, so go ahead and put your answers in. and then we can talk about it. Remember, it's anonymous. It's okay to be wrong. Does anyone need to see the rhythm again? I'm going to go ahead and close this one, okay? Alright, so we got some different answers. SVT, irregular, rapid, AFib, fib, VTAC, a flutter.
Lost.
Lost, crazy fast. Okay, so all kinds of different things. Okay, so the answer to this one would be a rapid AFib. So when we look at this, do we see any P waves?
I mean, yeah.
Yes, this is just, these are like those fibrillation waves that we talked about, right? So we don't necessarily have any organized P waves before every QRS. Is our QRSs regular or irregular?
Irregular.
Irregular, right? These are not evenly spaced. So I should have another one right there. See, they don't all have the same intervals in between. All right. And is the QRS normal? Is it wide or narrow, rather?
Narrow.
Narrow. So we know it's coming from somewhere higher in the heart, like AFib tends to do. All right? And so that's how we say it's AFib. So a heart rate of 148, rapid AFib, would that be somebody who's doing okay or not? No. Okay. So what are we going to want to do for them? You're just going along. When you started out, their heart rate was 93 in AFib, and the nurse said, oh, yeah, they're fine. They're always in AFib.
Check the patient.
Check the patient, and she's feeling a little short of breath, and she looks a little sweaty. She's got a cough.
C.
Condition C, right? That's something different. That's something out of her baseline, out of her norm, to start having these symptoms. So we're starting to get concerned that she has some clinical deterioration, right? Okay, so we'd want to call a condition C. All right, so what about this rhythm? I'll come back to it in just a second. The heart rate's 78. Think about it, is our QRS narrow or wide? Do we have a P for every QRS? Regular or irregular? All right, so we got some different answers: atrial, ventricular, sinus, irregular, junctional. Some mentions of heart blocks, fizzle. All right, so looking at this rhythm, this would be a more controlled AFib compared to the previous one, right? So how do we know that? What are some things that we can look at?
Irregular.
So it's irregular. Do we have a P wave for every QRS? Do we have any P waves? No P waves. All right. Is our QRS narrow or wide? Narrow. Okay. So I know somebody mentioned a junctional rhythm or a heart block. So if you had heart blocks, you'd still be having P waves. So that's how we can kind of rule those out. And then normally a junctional rhythm would not have such a good heart rate. It would be closer down like around 50s. So the fact that the heart rate's 78 or so, we can say that it's probably AFib, because whoever put that's right. Sometimes a junctional rhythm, usually you don't have P waves. So the heart rate's a way you can kind of try to figure out, is it junctional or is it AFib? Does the patient have a history of AFib? So that would be something to get some information to get from the nurse. All right, what about this one? I'll put it back up.
Did I change it? It's close.
All right, so it just took a minute to load. So I'm seeing a lot of VFib up there, some torsades, and atrial flutter. So we know it's not atrial because we don't have any QRSs, right? So atrial flutter, your baseline would kind of look like that, but then you would have regular QRS complexes. So we're going to rule out that it's anything atrial. So this would actually be VFib. So I could see how it could be confusing for torsades a little bit because it looks different here compared to here, here, and here. It's like this looks similar and those look similar. So I see how that could be confusing. So this would be like a coarse VFib. Okay. So how do we know that this is VFib? It's just a mess, right? It's just chaotic. There's really no organization to it. Did you have a question? Okay. So, yeah, really, like you said, it's just kind of a chaotic mess. Is this patient going to have a pulse? Are they ever going to have a pulse? No. So, whereas like VTAC, they can have one. VFib, they will never have a pulse. They're always going to be clinically dead. All right, so what are you going to do if they have this?
Condition A and CPR.
Condition A and CPR. Good, right away.
Girl.
All right, what about this rhythm? The heart rate's about 74. Do you have anything extra there that's not on most rhythm strips?
Mm-hmm.
Is it something the heart's doing is, or is it something else is doing? Yeah, they could have a pacemaker, it looks like. So what kind of pacing would this be?
And then,
All right, so yeah, we have pacing. They look like PVCs, but they're not because we have our pacing spikes. So here we have our two pacing spikes. We have our atrial spike and our P wave, and then our ventricular spike and our QRS with our T. So then we would say that this is what kind of pacing? AV. So both are paced, right? You could use two pacing spikes for each beat, essentially. So you have a spike for each P wave, and you have a spike for each QRS. So right, that would be AV pacing. So what are some questions that you might want to ask the nurse during safe handoff? Is it normal? Yeah, does the patient do they have a pacemaker? Hopefully the answer is yes if you're seeing that. All right. You can ask them, do they normally pace all the time, or is it only sometimes? Try to get a sense of what their baseline is like. All right. What about this one? Does it look good?
no.
So think about what kind of activity there is, or what kind of activity is not there. So flat line, yeah, or we would call it asystole. Dead breath. All right. Yep. So condition, you'd want to call a condition for that. Absolutely. What kind of condition would we call?
A.
Condition A. So, okay. So it's asystole, right? So there's no systolic activity. Remember, systole is like the contraction of the heart when we think about how the heart works. So it's asystole, the absence of systole. Nothing's happening. All right. So it can't be PEA because we don't have anything there, right? PEA would be like if it looked okay, just like nothing. All right. And so yeah, this person right here is absolutely correct. They are dead. So you have to be doing CPR, okay? And then somebody's calling the condition A.
Isn't it important to also know the status before you take a patient? Because I don't want to do CPR on somebody who's a DNR. We got in trouble for doing that before.
Absolutely, that's essential to know. And that's part of a safe handoff, getting a proper report from the nurse. Knowing what their orders are. All right, so what about this one? Heart rate 72. Regular or irregular? So atrial flutter. So we have regular QRS complexes, right? So these are regular. And then we have these flutter waves. And so that's how we know that it's atrial flutter, right? Because of those characteristic flutter waves. And so having the QRS is regular also clues us into that, because we know that atrial flutter, unlike AFib, is usually very regular. Okay? What are you going to do for this patient? Ask them if they're okay? Yeah? What do we want to know anything from the nurse? If it's normal for them, if it's their baseline? Somebody might already be in this rhythm, or you might be going along and then it happens. What if their heart rate looked like that with that pattern, but it was 172 instead of 72? Call a condition, what kind? A C, right? Because then we're getting into that rapid atrial flutter. It's kind of like rapid AFib, where they're going to start having symptoms. They're not going to feel good. Okay, and we want to make sure that we catch that and fix it before anything worse happens. So what about this? Heart rate's 38. We have a P for every QRS. Are we regular or irregular? Is QRS narrow or wide? Brady something, bradycardia, sinus, regular Brady. So these are all on the right track. So this would be sinus bradycardia. So, when we think of normal sinus rhythm, we think of a rhythm having a P QRST and having a P for every QRS, having a regular rhythm, and having a narrow QRS. So the fact that it looks like sinus rhythm is kind of what helps us figure out that it's sinus Brady. How do we know that it's bradycardia? 38, right? Yeah. So what's our cutoff for bradycardia? 60, right?
60, yes.
Okay, so we know that because it's less than 60, but it happens to look like normal sinus rhythm, that's how we know it's sinus bradycardia. Okay? Does anyone have any questions about that? So what about this one? Heart rate's 122. Do you have a P for every QRS? Alright, so taggy, normal sinus, so all on the right track. So we know it's not AFib because we have P waves, right? Mm-hmm. So how do we know it's sinus tachycardia?
Regular.
It's regular.
The heart rate.
The heart
Rate's
rate's
122.
greater than 100, right?
Mm-hmm.
Do we have a P for every QRS?
Yeah.
Okay. Is our QRS narrow or wide?
Mm-hmm.
Narrow. Okay. Any questions about sinus tach? So what are some things that can cause sinus tachycardia?
Fever.
Fever, what else?
Electrical movement, like fast movement.
Yep, so like exercise. What else?
Coffee.
Coffee, caffeine, pain. You know, somebody might have some electrolyte issues. All kinds of things can cause tachycardias, okay? So we really need to just be able to recognize that and then have you guys let the nurse know, hey, this person has a fast heart rate. Because that's not normal, right? To just have a heart rate of 122, people shouldn't just walk around like that, right? So we want to let somebody know, that way they can get to the root cause of it and try to fix it, okay? Because eventually they might start having some problems, okay? Are they bleeding inside? Are they really dehydrated? Those are things that we need to know. All right, so which of the following is the most important consideration related to PVCs? So they're extra beats, not a rhythm. They can be benign, meaning no big deal, or they can be serious. They can occur in a pattern, or they can be unifocal or multifocal. What's the most important thing to know about PVCs? Good. So while these are all true statements, the most important thing is to know is that they're extra beats. PVCs alone aren't a rhythm. So if someone's having PVCs, we don't want to just say like, oh, they have PVCs. Well, they do, but what's their rhythm? Is it normal sinus with PVCs, or do they have AFib with PVCs? Those are important things to know. All right, so what about this one here? What would we call this? So I see unifocal in there a lot. So this would be normal sinus. So someone put it normal sinus with unifocal PVCs. So our underlying rhythm is normal sinus, right? We have a P for every QRST, but then we have these other extra beats over here. How do we know that they're unifocal? Because they look the same, right? So we know they're coming from one spot in the heart. All right, and what about this one? Think about the underlying rhythm in relation to the extra beats and what you would call that. So good. Normal sinus with multifocal PVCs. So we know that it's normal sinus because the rate is 70, right? And then we have two different looking PVCs. So that's how we know that they're multifocal. So what does that mean? They're multifocal.
More than one area of the...
More than one area of the heart?
Mm-hmm.
Yeah, so you know they're coming from different spots in the heart. Why are they wide?
Ventricular.
They're ventricular, right? So you know that they're coming from the ventricles, hence the name PVCs. Okay, so once again, there's an underlying rhythm always associated with it, and they're extra beats. They can be unifocal or multifocal, and they can occur alone, or they can come in patterns, where you have like one every other beat or one every third beat, things like that. So we can think about some of the causes: having your electrolytes off, maybe some caffeine, maybe you're not getting enough oxygen. So these can often be benign, but we want to let the nurse know, hey, your patient's having PVCs, or if you're transporting them and you notice they're having more and more frequent PVCs, that can be a bad thing, right? Because remember earlier we talked about that RNT phenomenon, where the patient can go into a lethal rhythm because the PVC can happen while the heart's still not reset. Okay, so it's important to know that, PVCs alone aren't necessarily a problem, but they can be if there's enough of them or if they happen at the wrong time. So that's why we have to let somebody know. That way, again, they can get to the root cause of it and find out what's causing it. Okay, so sometimes it might be as simple as giving them, some certain medications or electrolytes to get everything back on track. Okay. So for these last few slides, we'll talk about a few cases, okay? So the first case, Maria Davies is a 73-year-old woman being admitted from the ED, and she reports chest discomfort, nausea, and some shortness of breath. You're asked to transport her up to 10 South. So looks like she's in a rapid AFib. How do we feel about that? You're not taking that. That sounds like a smart choice. Right? Is this a safe patient for you to take?
No.
No. Why not? What could happen?
Anything.
Anything could happen. Right?
Definitely going to kick into condition A.
Yeah. So what's something you might say
What
To
she
the
said.
to the nurse?
Does she
I'm not taking it.
I don't think
Yeah.
I should take that.
Yeah.
I'm positive I should take
Right? So you would want to explain to her, like, it's not safe for me to transport this patient. Something needs to be done. Right? So that doesn't sound like the picture of a stable patient. What if the heart rate was, in the 70s and they were still in AFib, but the patient says, I feel fine? Then what do you want to know?
make sure that they have like a history of it?
Make sure that's their baseline. You have to make sure they have a history of AFib. Anything else?
Like while they're here, right?
Yeah, while they're here, get some background. And then, if everything was okay, if you were told everything was okay, would you still transport that patient?
If you feel comfortable.
Yeah, right? They're in a controlled AFib, they might have a history of it, and the patient feels fine, nothing's bothering them, then yeah, AFib alone, isn't necessarily dangerous, especially if they have a baseline of it and they're, stable, they're not having any symptoms. Okay? And then, so it's a really busy day, you got lots of trips. So next you're scheduled to transport a patient from 6D down to CT scan. And the patient's in normal sinus rhythm at a rate of 72. And right before you leave the unit, the nurse gave some IV pain medication. So you're on your way down to CT, and then you see this rhythm on the monitor. So the heart rates are around the 40s. So what rhythm do we have here? Sinus Brady. Good. So how do we feel about that heart rate of 40? They were normal sinus at 72 for another 40. You try to wake up the patient. Yep, good. You want to check the patient, so you try to wake them up. What happens? He's a little sleepy. Condition C, right?
Yes.
Is 40 good enough?
Mm-hmm.
Probably not.
No.
And the fact that he's getting a little sleepy, maybe he got too much pain medication.
Yeah.
Okay, so we have to think about that. All right, so next we have Emily Jackson. She's a 23-year-old being admitted for observation due to reported palpitations for the past day. The whole time she was in the ER, she was in normal sinus rhythm, and then you're asked to bring her upstairs, and on your way up, this starts to happen. Are we happy about that?
No.
Is she happy about that? No, so she's starting to feel a little funny feeling in her chest. She just feels a lot of fluttering in her chest. She feels like her heart's racing. She's getting a little short of breath. Okay, so what rhythm do we have?
SVT.
So we have some SVT, okay? And then, so what kind of condition do we want to call? She's not feeling, you checked her, she's not feeling great. A condition C, right? So we want to get her some extra help that way, because they're probably just going to, give her some medication and that heart rate's going to come down, okay? But we need to do that before she gets worse, right? What if she went into that and then went back into normal sinus rhythm? Still call it? Yeah, I think that's a good choice. All right, so you're asked to transport a patient from 3E to X-ray, and they deny having any complaints. It's just resting comfortably on the stretcher, and this is the rhythm you see.
We should have asked the nurse if the patient is pacemaker.
So you ask the nurse if the patient has a pacemaker. Good. What else do we want to know?
Is that right?
Like, is that their baseline? Like, do they always pace every beat?
Yeah.
Okay. And you already talked to the patient. He says he feels fine. He's comfortable. Just wants to go get the X-ray over with so he can get back to sleep. Get back to his chair. All right. So are you comfortable transporting that patient?
Yeah.
Okay. What if you are on your way down to X-ray and you started seeing pacer spikes but didn't see a heartbeat after it?
Call
Check
the
the
patient.
patient.
Well, so what do you need to do first?
We'll check the patient.
Check the
Sorry.
patient, right?
I thought we were past checking.
Hey, you okay?
And they have pacer spikes, and they only have a heartbeat every once in a while. They only have like 3 of those are heartbeats. The rest are just pacer spikes.
I think that's a
So he's kind of groggy, just kind of groaning there.
You do a C.
Yeah, so call condition C. But obviously, if they didn't have a pulse,
Okay.
then a condition A. Absolutely.
You did okay.
All right. And so now you have to take a patient from the ICU to 10 South. They're being kicked out of the ICU. It's time to go to the floor. And the nurse tells you she's just really busy. She doesn't have time to talk to you. Just like take the patient to the unit. She'll call a report when she gets a chance.
Nope.
Like, she's really busy. Get them out of here. I've got a new admission coming from the ER in a few minutes. Like, I need you to get them out of here. She'll call when she's got some time later.
No way.
No, right?
No.
Why not?
We don't know
You don't know anything about the patient,
Some
right?
nurses have to transport out of the ICU.
Do they have to here?
Yeah.
Do they what?
Do the nurses have to transport from the ICU?
Yeah.
No.
Yes.
Yeah.
Unless they're not on.
Yeah.
Unless they're not on.
It's-
Not
But we have to transfer everybody out.
Yeah.
Okay.
Slippery slope.
So it depends.
It's
Okay.
nursing judgment.
Everything.
It's nursing judgment.
But good catch.
Yeah.
All right, so next you have Ed Smith. He's a 54-year-old being admitted for severe dehydration. He's been having vomiting and diarrhea for days. And you're taking him to 8 North, and his monitor shows this rhythm. So what rhythm is Ed in? So he's got some sinus tach. Okay, how do we feel about that, given his history? He got some fluid in the ER, now he's going upstairs, he's going to get some more IV fluid. He's still having some vomiting once in a while.
Why can't he be transported with some fluid? Why can't you?
Ask them like what his baseline has been in the ED. If
Yeah,
he's
so
a
how
normal,
has
like,
he
now.
been?
Yeah.
Has he been in sinus tach since he's been here? Has his heart rate improved? So, if he's 120 now, was he 140 when he came in? Is he getting better, or is he getting worse? Has he been about the same?
Right.
So, trying to find out how he's been, getting a report from that nurse is vital. Okay, but otherwise, how would you feel about transporting him?
It's all right.
All right, if he's not having any other symptoms, he's throwing up once in a while.
You quit.
Okay. So next, you complete the safe handoff prior to transport, and you're told that the patient's in normal sinus rhythm with occasional PVCs, and you look on the monitor and you see normal sinus. Once in a while, they'll have a PVC, and then during transport, this is what you see on the monitor. You're halfway to the floor. You're on the elevator on your way up.
Hop
Check
off
the
the elevator.
patient.
Get off the elevator first.
Check the patient.
So you're going to check the patient,
Check
right?
for a pulse.
The patient doesn't have a pulse. Okay. What if they have a pulse?
Condition
C.
Condition C, okay. And do you want to, what if there's no one around? Are you going to go running?
Yes.
Say, help, my patient's in. No, is that a bad idea?
Yeah.
Okay, what do you want to do while you're waiting for the code team to come?
Stay with the patient.
Stay with the patient.
Stay with the patient.
Yeah,
What
just-
else?
Note any changes.
Okay.
Strip.
Yeah. Print off a strip, see if anything changes while you're there. Obviously, you're doing CPR if they don't have a pulse.
Yeah.
What do we want to do with the stretcher?
Lock
Make
it.
Lock it.
Make sure it's down.
Yep, put it at a good height for you. You know, you don't want to have to hop up on top of it to do CPR. All right. So, you know, getting ready for the code team to get there. What's something you might want to tell the code team when they get there?
To how they
Patient has
stored it,
Like what
the
happened?
rhythm
Yeah,
stored
so
it, and then it just-
what would be an example of your S-bar?
He was fine, then he kicked into this.
Yeah, so you want to, you know, say like, oh, you know, I was transporting him to the floor and he was in normal sinus rhythm with occasional PVCs, and then all of a sudden he went into VTAC, and now I'm doing CPR, and I really need some help here.
He had like 20 hours.
Right? You just want a brief history of what's going on, not to tell them everything.
It never does that calmly, like, trying to tell them.
All right. And then so finally we have Kevin Johnson. He's generally a healthy 19-year-old college student coming into the ER, and he feels like his heart's just skipping some beats once in a while. What's going on?
Yeah, he just got
PVC. So what kind of PVCs does he have? Unifocal. Okay. And what would you call this rhythm? Normal sinus with unifocal PVCs, right? So, you know, after talking to Kevin, you find out that he's had a lot of exams. He's been staying up late, drinking a lot of energy drinks. So what do you think could be causing these? Some electrolyte issues, maybe a lot of caffeine. Maybe he's, you know, really pounding the energy drinks back, and now he's on PVCs. Okay. How would you feel? Would you feel comfortable transporting him?
Depends on like how he's been doing in the ER.
Yeah.
Depends on how he's been feeling, right?
Yeah.
Has he been, you know, has he had a lot of PVCs? Are they only once in a while? Obviously, he's feeling his heart skipping beats. You know, it could just be some increased anxiety. That, you know, he's just more aware of it happening. But is he short of breath? Is he having any chest pain? Any mental status changes? Or does he feel like his normal self? All right? So I would like to thank Terry. She's been an excellent preceptor. She shared a lot of wisdom with me. All right? And obviously my course faculty has been instrumental in preparing me to this point. And I'd also like to thank the nursing education department here. All right?
And us for listening.
And you listening.
And you guys too, we want to thank you. We want to thank you for
So I
participating.
really appreciate you guys participating, okay? So I will ask that you guys do an evaluation of this review session. I want to know if it was helpful for you, if there were things that you liked or didn't like, if there's anything that you would change, okay? The only way I can get better is if I have feedback, and so that's something that I'm looking for, okay?
Yeah, just kind of hover your camera over, is that what?
Yeah, so just hover your camera over and it should come up with a survey.
You can come up here more if you
Thank
need.
you again.
What do you, that's your camera?
Just watch.
Yeah. Yeah, and then just zoom in.